heart attack, also called a myocardial infarction, MI, happens when blood flow to part of the heart is reduced or completely blocked, leading to damage or death of the heart muscle. The most common sign is chest pain or discomfort, often spreading to the left shoulder, arm, or jaw. Sometimes the pain can feel like heartburn. Other symptoms include trouble breathing, nausea, dizziness, cold sweats, fatigue, and even loss of consciousness. About 30% of people experience unusual symptoms. Women, in particular, might not have chest pain, but may instead have pain in the neck or arm, or just feel very tired. Older adults, especially those over 75, might have a heart attack with very mild or no symptoms at all. The most common cause is a complete blockage of a coronary artery due to the rupture of a plaque, a buildup of fatty deposits in the artery. Less commonly, heart attacks can be caused by spasms in the coronary artery, triggered by factors like cocaine use, intense emotional stress, known as takotsubo or broken heart syndrome, or extreme cold. Chest pain is the most common and important sign of a heart attack. This pain is usually described as tightness, pressure, or squeezing, and often spreads to the left arm, but can also move to the jaw, neck, right arm, back, or upper abdomen. Pain that spreads to the right arm and shoulder strongly indicates a heart attack, and pain similar to a previous heart attack is also a clear warning. The pain usually lasts more than 20 minutes and doesn't change with body position. It can also feel like unexplained anxiety, and in some cases, there might be no pain at all. Other symptoms of a heart attack can include sweating, nausea, vomiting, fainting, dizziness, and shortness of breath. These symptoms can occur with or without chest pain. Women often experience different symptoms than men, such as shortness of breath, weakness, fatigue, nausea, jaw pain, neck pain, back pain, and difficulty breathing. Shortness of breath can sometimes be the only symptom, especially if the heart is damaged and cannot pump blood effectively. Loss of consciousness and sudden death can also occur if the brain doesn't get enough blood due to the heart attack. In some cases, heart attacks can occur without any symptoms, known as silent heart attacks. These are often discovered later through tests like electrocardiograms or blood tests, and are more common in older adults, people with diabetes, and heart transplant recipients. The main cause of a heart attack is the rupture of atherosclerotic plaque in the arteries that supply blood to the heart muscle. When these plaques break apart, they can trigger the formation of a blood clot that blocks the artery, which can happen very quickly. This blockage prevents blood from reaching the heart muscle, leading to tissue damage. Atherosclerotic plaques can be present and build up over many years before causing any symptoms. Atherosclerosis is the gradual buildup of cholesterol and other substances in the artery walls over decades, leading to inflammation. This inflammation attracts cells like macrophages, which absorb cholesterol and turn into foam cells. These foam cells die and form a cholesterol core. To stabilize the plaque, smooth muscle cells move in and form a fibrous cap, which may become thick and calcified. If inflammation continues, the cap can thin or break, and the plaque may rupture under blood pressure, leading to a blood clot. Other causes of heart attacks include conditions that increase the heart's oxygen needs or damage heart procedures like PCI or CABG. Coronary artery spasms, such as those seen in Prinzmetal's angina, can also cause heart attacks. When blood flow to the heart is blocked for too long, it leads to a process called the ischemic cascade, where heart muscle cells die and are replaced by scar tissue. Without oxygen, the cells can't produce energy and eventually die, leading to irreversible damage. The area of heart muscle most affected is the endocardium, the inner layer of the heart, which starts to die within 15–30 minutes of blocked blood supply. The damage and scarring from a heart attack disrupt the heart's normal electrical pathways and can lead to irregular heartbeats, heart block, or even heart wall rupture, which can be life-threatening. A myocardial infarction is diagnosed by elevated cardiac biomarkers showing a rise or fall over time and at least one of the following: symptoms related to reduced blood flow to the heart, changes on an electrocardiogram (ECG), such as ST segment elevation, new left bundle branch block, or abnormal Q waves, altered heart wall motion on imaging, Presence of a blood clot, thrombus, seen on angiogram or autopsy. Heart attacks are mainly classified as ST elevation MI, STEMI, or non-ST elevation MI, NSTEMI, based on ST segment changes observed on an ECG. STEMIs account for about 25 to 40% of all heart attacks. There's also a detailed classification from 2012 that includes 5 types. Spontaneous MI, caused by plaque rupture or dissection. Ischemic, due to conditions like coronary artery spasm, embolism, anemia, or arrhythmias. Sudden cardiac death, where a heart attack is suspected but biomarkers are not yet available. Procedural MI, related to coronary angioplasty, stenting, or PCI. MI, associated with CABG. Related to surgery or spontaneous coronary artery dissection in young, healthy women. Cardiac biomarkers. Troponins are the most reliable biomarkers for detecting heart muscle damage. They rise within 2 to 3 hours after injury and peak in 1 to 2 days. Changes in troponin levels help diagnose or rule out a heart attack. Other tests like CKMB or myoglobin are less preferred because they are not as specific. Electrocardiogram, ECG. An ECG measures the heart's electrical activity and is crucial for diagnosing a heart attack. Key changes include ST segment elevation, T wave inversion, and new Q waves. ST elevation in specific leads can indicate an ST elevation myocardial infarction, STEMI. Imaging. Non-invasive imaging, such as echocardiography, helps visualize heart structure and function. Chest X-rays and echocardiograms can identify alternative causes of symptoms and assess heart wall motion. Nuclear scans like SPECT and PET can show blood flow and tissue viability, but are usually reserved for cases where initial tests are inconclusive. Differential diagnosis. Chest pain can have many causes besides a heart attack, including angina, gastroesophageal reflux disease, pulmonary embolism, pneumonia, and musculoskeletal issues. More severe conditions like aortic dissection or tension pneumothorax can also mimic heart attack symptoms. Other causes of sudden breathlessness include pulmonary edema, asthma, and respiratory distress. Fatigue alone is generally not a sign of a heart attack. Preventing and managing myocardial infarction, MI, involves a combination of lifestyle changes, medications, and medical interventions. For primary prevention, it's important to engage in regular physical activity, 150 minutes of moderate or 75 minutes of vigorous exercise weekly, and maintain a healthy diet rich in unsaturated fats, whole grains, fruits, vegetables, fish, and nuts. Avoiding smoking, moderating alcohol intake, and maintaining a healthy weight are also crucial. In terms of medication, statins are recommended to lower cholesterol and reduce cardiovascular risk. The use of aspirin for primary prevention is debated due to potential bleeding risks, but it may still be advised for some individuals. In acute MI management, STEMI, ST elevation MI, typically requires prompt treatment with either thrombolysis or percutaneous coronary intervention, PCI. PCI is preferred within 90 to 120 minutes of symptom onset. NSTEMI, non-ST elevation MI, may be managed with PCI within 1 to 3 days if the patient is at high risk. Pain management often involves nitroglycerin and opioids like morphine, though the benefits of morphine are less clear. Antithrombotics such as aspirin and P2Y12 inhibitors are used to prevent further clotting, and heparins may be added. For those who have experienced an MI, secondary prevention focuses on lifestyle modifications similar to primary prevention, quitting smoking, eating a healthy diet, and resuming exercise gradually. Medications include continuing aspirin and possibly other antiplatelet drugs, starting beta blockers and ACE inhibitors, and using statins to lower cholesterol. Devices like defibrillators may be recommended if there are ongoing heart failure or arrhythmia concerns. Prognosis varies based on factors like age, heart damage, and treatment effectiveness. Survival rates have improved with better treatment, but outcomes can still be serious, especially for those who experience complications. Neonatal MI is rare but has a high mortality rate. Survivors generally have a normal quality of life. In summary, managing and preventing myocardial infarction involves a multifaceted approach. Effective primary prevention focuses on adopting a heart-healthy lifestyle and making dietary adjustments, while medication plays a crucial role in reducing cardiovascular risk. For individuals who have experienced an MI, ongoing management includes lifestyle modifications, a range of medications, and possibly medical devices to support heart function. Timely and appropriate treatment during an acute MI, such as PCI or thrombolysis, can significantly impact outcomes. The outlook for those affected by myocardial infarction has improved significantly, though careful management remains essential. Please click on the next video for more Live Good info. Thank you very much.